clockwise. Good evening and welcome everybody here at 1 Wimpole Street and everybody joining from around the world. We have the pleasure of welcoming Simon Lambert, Ron Doddenhoff and Will Good to discuss their personal journeys and experiences within the field of tissue restoration and augmentation. Ron and Simon will both present their experiences with Artelon across different indications within the shoulder. A quick background on Artelon for those that don't know. Artelon was developed by the esteemed Dr. Lars Peterson. His mission was to find a solution to why other synthetic grafts such as Dacron, PE and Gore-Tex were failing. History has shown that they were non-kinematic and non-regenerative. So Artelon was developed to restore stability and natural motion, resist necrosis, and regenerate natural tissue through load sharing. For anyone who is interested in the evidence behind Artelon, please let us know and we can send you away with some bedtime reading. Without further ado, I would like to introduce our chair for the evening, Mr. Will Good. Will has been a consultant trauma and orthopedic surgeon for 10 years and is currently clinical director of the orthopedic department at Walsall Manor Hospital. Over to you, Will.
Thank you very much. I'm delighted to be able to welcome two such eminent and well-respected surgeons as Ron Doddenhoff and Simon Lambert to discuss this issue. I think as shoulder surgeons, it's something we all struggle with a bit with rotator cuffs. We know the ones we definitely should repair, and we know the ones we definitely can't. And there's that huge grey area in between where the tissue is of variable quality, and we don't have a perfect answer for it. But certainly the experience of my two colleagues with Artelon looks very promising, and they're going to present their experience, which I think will be invaluable and very interesting. So first of all, I'm going to go to Mr. Ron Doddenhoff, who's a consultant at the Robert Jones and Angus Hunt Orthopaedic Hospital in Oswestry Street and Princess Royal Hospital in Telford, has got a wide experience of using Artelon. Over to you, Ron.
Hi, thank you. Good evening, everyone. So, Will's already mentioned the cuff tear, one of the commonest things that we deal with in our surgical practice. And we all like to think that we have the answers, but we know there are patients where we just cannot work out what's the best thing to do. The ones we can definitely do, we know, but there's a group of other patients which is getting smaller and smaller, but it's getting more and more difficult to manage. So the patients with the poor quality tissues, delamination, gross retraction, or particularly the ones that trouble me, you've had a successful initial repair and the patient comes back 6 to 12 months later and they've retorn with a healed initial repair. So it's not surgical failure, it's failure of tissues. And I think part of this is we sometimes forget that what we often see is a snapshot when we see a patient. We see them at a point in time. But this is an evolving dynamic situation. Once you've repaired that tendon, you still have a patient who's getting older. Their tissues are still degenerating. It's an aging population, and that aging population is getting bigger and bigger. And the tissues will be becoming poorer and poorer. So this is going to become a more significant issue as the years go by. And something in the region of 56% of 2 tendon tears, which is successfully repaired, will at a later stage re-tear. So it is an issue. So we might think we've got the answers, but there is definitely a difference between the reality and what our aspirations may be. So I started augmenting cuff repairs some time ago, precisely for these reasons. So ideally, that augmented repair, we want something which allows tissue ingrowth. So it's got to have some biological function or biological supportability. And we want something which provides a strong mechanical scaffold, something which allows you to get that fixation on poor quality tissues at the time. And that supported tissue will then have a much greater chance of healing, and just as importantly, allows us to mobilize the patient and rehabilitate them. So fundamentally, there are two main types of augmentation that you can use. There's the biological scaffolds, whether they are allograft, the patient themselves, tentis fascial lata, for example, autograft or allografts coming from either donor human tissue, pig, cow or horse, a little bit like a cheap lasagna. So one of the common ones we use, and one I've used quite a lot, is the graft jacket, which is human dermal tissue, but there are plenty of others on the market as well. They all require processing to remove the antigenic material, which will otherwise stimulate either irritability, inflammation, or rejection. So they require quite a lot of work. So as I say, in Oswestry, we've used graft jacket for many years. I love the terminology on all these things. The graft jacket, max force extreme. You know, it sounds like you're selling Coca-Cola rather than anything else, but it works and it's a good tissue. But it's thick, it's heavy, it's hard to manipulate. So maybe there's something better. And that's why I turned to start using Artelon, which is a fully synthetic material, polyurethane urea. It's got very good handling properties. It takes a stitch very well, and we'll talk about what we can do with it. So Artelon, it's synthetic, so it provides a temporary tissue support and a scaffold. It degrades and integrates over the course of 6 years, but it retains a lot of its tensile strength for a long time. The biologicals predominantly will lose 50% of their tensile strength between 6 and 12 weeks after implantation. Artelon maintains 50% of its tensile strength for up to 4 years, so it gives you a much longer window, and up to 90% of its tensile strength in the first 12 months. So again, during that critical rehabilitation period, you have a strong scaffold support. It's got very good biocompatibility. It's synthetic, so it won't promote allergic reactions. And I find it's got very good handling properties. And I think Simon will talk a little bit about this later. It takes a stitch really well. It stretches, it allows you to cover that defect and get a good degree of tension and coverage. So I much prefer it to a biological. So we'll talk a bit about the indications, a little bit about the techniques. There's nothing very fancy about those. They can be performed open or arthroscopically. Some of the published results and my personal experience. So indications, we've touched on them already. We have an elderly population, a population which is getting proportionately older as time goes by. Inevitably, they will have poor quality tissues. So we do see these very thin, attenuated tissues with delamination. You try to grasp them and they just pull straight through. So performing a primary repair on poor quality tissue is doomed to failure. And then we have this second group, those who've had an apparently successful repair and re-tear at a later stage. Re-repairing a re-torn rotator cuff, it's that definition of madness, isn't it? Where you do the same thing repeatedly and expect a different outcome. So rather than simply re-repair it, we want to look at something which helps you to support it and augment it. In my opinion, and in my experience, this works really well if you can perform the repair directly and use this as an augmentation. I have used it as a bridge, but I prefer not to use it as a bridging technique, but it does work as a bridging technique. But if you can augment and support the repair, this works absolutely like a dream. We'll talk about that in a moment. So the technique, whether this is open or arthroscopic, it's a repair of the tendon, tensioning that graft over the repair, because this tapes a little bit like a skin graft. If you have what's effectively a parachute sitting over the top of the rotator cuff, the only points where you're going to get neovascularization are where those sutures are attached, and you will not get adequate ingrowth into the whole of the tissue. And that's the case whether it's a biological or a synthetic. So you want to get those capillary loops growing up into the tissue. That allows collagen ingrowth and then eventual remodeling, which should be between 12 and 24 weeks, where you're starting to see good signs of new tissue developing. In the same way that when we fix a joint fracture, if you have a stable fix, you can then adopt a fairly aggressive early rehabilitation program, and that's going to have big advantages in terms of getting this patient back to activity. So it can be done arthroscopically. I personally don't think I've got the arthroscopic skills to be able to do this well, mainly because you are going to end up predominantly fixing this at points. And I find it difficult to tension the graft adequately doing it over points. If you can do that, brilliant, but I much prefer to do an open technique. So what you want is something like that, a nice, smooth, fixed graft over the top, which is tensioned adequately. So you start at one point, start at the 12 o'clock point, and gradually work your way around, tensioning as you go so that there are no weak spots and there are no gaps between the host tissue and the augmentation. What you don't want is something like this, where again, we've got point fixation and probably inadequate fix. Also here, you're going to have edges which can lift off as the patient moves, so you can start to get rolling up of your graft, which is not ideal. So when I first started doing these, I would arthroscope people at the drop of a hat to see what they looked like. So anybody who complained of anything, aching, discomfort, pain, clicking, I would scope them so I could see what it looked like. So here's one which was actually done as a bridge graft. So we can see some sutures here, but fundamentally, this was an Artelon graft. We go back to that one again, I think. Try and get that one back for you. Fundamentally, that looks like normal tissue to the naked eye. And this is on the joint side. You get the same appearance on the bursal side. Something that looks like you've never been there other than the presence of some sutures. So if you get the technique right, you will get ingrowth and you will get something that does exactly what you want. So this is Artelon. This works really well. So the results, fairly similar between the biologicals and the non-biologicals. So graft jacket, good increase in constant Murley score. Artelon, again, good increase in the constant Murley score. My personal results, again, I've used a mixture of both. So my first 5 years of using it, operated on 45 shoulders, predominantly primary cases where I'd made the decision at the time, consultation with the benefit of an MR scan showing a poor quality delaminated tendon. 16 cases where re-tears or patients where at arthroscopy, I saw that I could repair this, but the tissue quality was so poor, it would be almost inevitable that this would tear again. So I would bail out and then bring them back 4 weeks later to perform an open repair. So all done by the same surgeon, all done using a standard open technique. There's nothing fancy about the technique. It's a normal 2-row repair. Medial sutures fixing the tendon down, lateral sutures to snug the edges, fix the graft with continuous ethibond, make sure the graft is tensioned down so you don't have any gaps between the host and the donor. And I now incorporate the lateral row sutures into the very edge because that's often the most difficult part to be able to stitch down, is just that lateral edge of the graft. And the worry is if you don't get that secured, it will roll up as time goes by, and then you'll have a problem with getting it to incorporate properly. So again, by 18 months, 39 out of 45, functional, comfortable, able to do all their day-to-day activities. 3 patients still complained of pain. 2 patients retore. Interestingly, both had about 3 years, suggesting that probably these had never incorporated for whatever reason. And then as the tendon augment became weaker over time, eventually gave up the ghost, but that was after 3 years, and they were awaiting surgery prior to the COVID pandemic and are still waiting. Only 1 patient was stiff post-operatively, who underwent an arthroscopy and release. I feel, although with these numbers it's difficult to prove, I feel that you have less pain with the Artelon group, probably because it's synthetic, so you don't get the same degree of inflammatory reaction, you don't get the potential allergic or rejection type issue. So that's my gut feeling, the Artelon patients do better. It may be as simple as the fact that Artelon is much thinner, and because it handles better, I can snug it down better. So it may be a mechanical thing, but I feel that they get less pain with Artelon than they do with a biological. And in my series, I had no infections. In the whole of the unit, we've had 1 infection, and that was using a biological rather than an Artelon. So although it's a reasonable amount of foreign material, it incorporates well. So people started using it for things like superior capsular reconstruction as well. Just a very brief bit about SCR. So it developed in Japan in 2007, and based on the principle that the superior capsule acts as a significant passive stabilizer because of its attachment to the greater tuberosity. Defects in the superior capsule lead to significant translation and subacromial contact pressure increases, which then cause secondary problems with the cuff and shearing of the joint cartilage, leading to secondary osteoarthritis. So the idea is that if you can reconstruct that superior capsule, can you improve the stability and restore the force couple? So the indications, I think, and from speaking to colleagues who perform this procedure, they are very limited indications. The massive irreparable cuff tear, but with an intact anterior and posterior tendon structure, or at the very least, a tendon that is repairable. Even that is a bit controversial, because if it's already got to the stage where your subscapularis is torn, you're repairing, by definition, poor quality tissue. So maybe we're just changing the problem again to the one we used to have with the supraspinatus itself. And crucially, no arthritis. You've already missed the boat if you've got an arthritic shoulder. Again, can be performed open or arthroscopically using allografts or autografts. The medial anchors go into the superior glenular tubercle and the lateral anchors into the greater tuberosity, and then a side-to-side repair to the anterior and posterior tendinous structures. So you're trying to provide that new balanced force couple so we can recruit the remaining muscles to work with a centered humeral head. The benefits of allograft should be biocompatibility, but the synthetic, as we talked about earlier, it's got greater mechanical strength, both initially and later on. And because it is synthetic and it's manufactured, we should have a greater ability to control its chemical and physical properties, so it should be more consistent. The results of SCR are encouraging. It is probably the next big thing, and certainly the surgeon in my unit who does this, he's had some very impressive results. But fundamentally, if you stabilize the glenohumeral joint and get the head centered again, you will improve your active elevation, because you can now recruit your deltoid much more effectively. And hopefully, long term, this will be part of the answer. But there's a lot we don't know about all of these things. We don't fully know how to rehabilitate people. I treat patients with any kind of augmentation graft in much the same way that I repair any other primary tear that's been repaired. I rehabilitate them exactly the same way. We don't know what the time to failure is. In my series, 3 years, if a graft hasn't incorporated, seems to be the time. We don't know whether there are any long-term complications, but I've been using this now for, how long, Fiona? 10 years? Ooh, yeah. Something like that. So there don't appear to be any. What's going to happen when we do revision surgery? I suspect there won't be a problem at all, because by the time they come to revision surgery or arthroplasty, this will all have incorporated, and what you'll be operating on will be the same as any other patient. And then the choice between biological or synthetic. Personally, I prefer the Artelon because of its handling properties. So I think it's a great get out of jail card. This is something when we have that difficult subgroup of patients. In my hands, it's an augmentation, not a replacement, but it can be used to bridge an irreparable tear, and it does work. But it works best if you can augment it, because then you get that ingrowth much quicker. Use the best technique for you. The outcomes will be the same if you're a good arthroscopist or a good open surgeon, as long as you do the procedure correctly. The aim is to get a tensioned, solid, stable graft that you can mobilize the patient with very quickly, and you do what's best for you. And obviously, maybe augments will not be necessary if SCR is truly the answer to all our prayers. Well, thank you.
Thanks very much, Ron. Interesting and thought-provoking. I'm sure there'll be plenty of questions once we've finished. But now it's over to Mr. Simon Lambert for his presentation, which I'm sure is going to be extremely interesting.
Great. Well, thank you very much indeed. Let's go. So why do I use Artelon? Those are some disclosures that I ought to talk to you about. This is a case study to kick us off. This lady is a very keen equestrienne, but it was her horse that injured her shoulder, one of those classic injuries where the horse reared up, being distracted by another car, and her left arm was dragged up into the air and she was dangling from the horse and her shoulder dislocated. Well, all of that sort of history would immediately tell you that there's something very potentially wrong about the rotator cuff and so on and so forth. And at her age, she was then about early 50s, she did have a very badly damaged shoulder. So she had capsular surgery and so on and so forth. What wasn't quite appreciated was how damaged the rotator cuff was. And it wasn't long before her subscapularis failed during the course of normal activities. And when the initial repair of that didn't really help, she eventually came to a pectoralis major sternal head transfer, which I did about 5 years ago. And for all sorts of reasons, that didn't work terribly well biomechanically. It worked perfectly well to power the shoulder, but only through a limited range. And I now think I understand much better how to do a pectoralis major transfer, but it needs to be augmented, and that's where synthetics come in. So we'll see this case later when I've gone through a few sort of bits of the rationale. She came back 18 months later, having re-injured her shoulder with another tear of the pectoralis major transfer, and presented recently, before we couldn't operate, but with persistent anterior instability and now arthritis. So she had the classic evolution of a traumatic injury resulting in persistent anterior instability and cuff disease. And so there was a question, much like Ron has presented, what do you do now to someone who's still young, still very active, still wants to be active, has had an unusual reconstruction which has failed and failed twice, and now has arthritis at the age of only 59. So the questions I sort of get to, what do I require for this soft tissue if I'm going to do something to heal optimally? And that, of course, is you want to use something to help you repair it, to provide a structural reason, a structural framework for a stable enough coagulum to start that process of healing. It's no good having, as Ron pointed out beautifully, just 1 or 2 points of contact and do a spot weld and expect a tissue lamina to develop strength. So we're, as surgeons, promoting these 3 things: reperfusion, that is using the existing capillaries, making new capillaries by tissue hypoxia, driving that process, and inosculation, which we talk about in bone, in radial head and talus and so on and so forth, but actually probably also happens in tissues, at the end of tissues, right at their the limit of oxygen diffusion. You get driving between capillaries that are opening up and joining with others, this process of inosculation. And I think we don't really, as it were, have a sense of that enough. I do want to have regeneration, to encourage appropriate cellular proliferation. I want something that allows the tissue to recognize a structure on which fibroblasts can begin to adhere and then to proliferate. And that's happening from the word go. So if you don't have a stable coagulum and you don't then generate this, as it were, proliferative formation of cells and therefore collagen, we break that healing cycle very early. And this is a business of early active mobilization. What we're expecting these rather difficult tissues to do, if we then want to move and put strain through the tissues, that is almost certainly in excess of what collagen requires. If you have a big strain, you will get fibrous tissue, but is that fibrous tissue going to be organized tissue? What I also want is that tissue to remodel. In other words, I do want it to respond to strain, but at a time when there is some viability, some vitality to the tissue. So you get this organized tissue, not just random tissue. And the metaphor I use for patients is, you can imagine the day after you've cooked spaghetti and what's left in the bottom of the pan has some structural integrity. You can lift it out of the pan, it comes out as one blob, but it's all completely disorganized. And if you pull it apart, it pulls apart very easily. Whereas if you cook lasagna and let it go cold, you try and pull it apart in a certain way, it won't. It can pull it apart in another direction, but you can't pull it apart in the line of fibers. And what you want in your healing tissue is lasagna, not spaghetti. And you can only get lasagna if you organize it. So you do have to put strain through the tissue, but at a time when it's ready to do that. And that seems to me to be something that we're not very clear about in individuals. Exactly, I agree completely with Ron's concluding remarks. When do we start rehabilitation? When is a tissue competent enough to do that? I've noticed that the writing is getting smaller and smaller and smaller. I don't quite understand that, but then that doesn't matter. We then want to rehab this tissue. We want to make it function, and function means responsive to neural inputs. So we want it not just to be a static, passive constraint. We want it to be an active tissue. Now, if you've got a block of dermal allograft sitting there, it will not re-innovate. There isn't a framework for re-innovation. Whereas if you create a porous structure that fibroblasts recognize as having a porosity that is conducive to swarming, to adhesion, and that is also vasculogenic, now you have the basis for a tissue that could be a responsive tissue. And that's what I like about this sort of thing. So when my tissues are suboptimal, what do I need? Well, I need, I'll do it on the, can I do it on this thing? Yes, I can. I need something that will either replace the tissue. Oh, it doesn't come up there, does it? No. Replace the tissue. And bridging isn't the strength of a mesh. That's where you do have to have some sort of tissue. Now, I happen to use bicep tendon as my replacement for rotator cuff because I don't like using bits of dermal allograft and bits of horse and cow. I don't think it makes sense really. But the intrinsic biceps is a very good substitute for the cable and so on and so forth. Julian McBurney talks about that in subscat repairs quite well. But I do want to augment what I've got there already, or reinforce it. If it's repairable, but laminating, and exactly as we said in the rotator cuff, you want to reinforce that tissue, then those are the sort of features that I would like. I also want a scaffold that provides an orientation, as I've talked about. I want lasagna, not spaghetti. And I want it to happen in a shorter space of time with the maximum efficiency, so the least amount of effort by the cells. So I want that distance to be as short as possible. And you do that by making the porosity ideal for fibroblasts to go, I know that one, I know that one, I know that one, just like bone cells. So this is coming straight from bone biology. And then when I've got that connectivity, I want that connectivity to be elastic. Now that means that the mesh that I'm using, or whatever it is I'm using, has got to have something like the coefficient of elasticity that the natural tissue does, Young's modulus, that the natural tissue does when it has been, as it were, sandwiched in the fibroblast layer. And it mustn't get in the way of that. It mustn't be stiffer than that, but it mustn't be too lax either. And that's quite nice. So you want a tissue that has directional orientation, that doesn't have a, let's say, a predisposed direction of failure. You also want something that enables tissue to form. You also don't want a foreign body response, because that undoes everything and does everything. And lastly, as I said before, I want a tissue that stays around long enough that it's going to support the reintegration of this tissue into normal activity. And I have this little thing in my head, don't I? And you know this, that I think of the capsule and the rotator cuff as basically an afferent field of proprioception. And what I want is to get that afferent feel back again so that I can control stability. And there is a very, very time-honored time frame over which this happens. And it doesn't change. It hasn't changed in millennia. It hasn't changed in 4.5 million years since Australopithecus stood up. We've healed at the same rate. We can undo it, we can make it worse, we can make it slower, but we can't easily regulate its upregulation, if you like. We can make sure it doesn't slow down, or you can take steps to prevent it from breaking down, but we can't actually make it work any faster, which is why accelerated protocols are risky protocols, unless you've got a substrate that actually works to support it. So I want something that will help me go through that 6-week, 12-week, 6-month and beyond type of framework. So ideally, at that 6-week mark, I want something that will retain sutures, that has a very low immunogenicity, because I don't want the inflammatory response to be prolonged. I want the inflammatory response because that's the basis of healing, but I don't want to be effervescent. And when I get to the point of regeneration, I want something that will support that over a 6-month time frame. And here, this comes from the pamphlet that you'll see from Lavender Medical. This is the 6-month view of tissue in which the white represents the artelon. What is absent is an encapsulation of that foreign material. It's not being cast aside. It's not being isolated like suture material. It's been adapted into the tissue, and the purple stuff, the toluidine blue stain, is in the collagen fibers. You can see them enveloping this material, and little later on, you get this orientation effect. So the artelon is the blue stuff, and the collagen fibers are the white and the gray stuff. So you see an integration of collagen with this mesh, which seems to me to be a lot better than having collagen sitting on the surface of an allograft up to a point and then retreating. So this type of idea is about enabling the host tissue response to be directed and efficient and completed. Oh my goodness. What do I need over what period? This is slightly odd. Never mind. What do I need here? I want this eventually to go away. And the collagen is the pink stuff, and the artelon is the little brown bits. So at about 5 years, the artelon's basically disappeared. And when I've operated on people at about that sort of period and up to a bit longer than that, what you feel is a slightly gritty feeling when you cut through. You know how we're taught in med school that if you cut something that feels like an unripe pear, it's cancer. Well, I'm afraid it feels a bit like that. It isn't, but it's that gritty feel that you've got when you've got a structure that has within it some residual foreign material. But the material itself has elasticity, so you can do a primary repair with that tissue again. So it regains tissue quality. That's lovely, because you actually feel like you rebuilt tissue. That's unusual. Going back to our case study, this is the lady. You can see there her pectoralis major transfer now fully exposed with the deltoid retracted laterally. She had grade 3, Samuelson grade 3 osteoarthritis. She had pain at night. All the features that you and I would say, actually, this lady could do well with a total shoulder replacement, but she's got very poor function in stability. And the pectoralis major tendon transfer, which is attached to the greater tuberosity, hasn't got any role in anterior stability at all, there being no capsule. So this lady survives on holding her shoulder with her pec major. Not a very good way. So it's a failing muscle transfer, really. I've shown you there the pectoralis major attachment, the proximal joint line. And what I wanted to do, of course, was to recreate some capsule, medialize the effective line of action of the pectoralis major tendon transfer, do the shoulder replacement. Yes, that was a given, but to reinforce that lateral footprint of the pectoralis major tendon transfer so that it not just stretched out over time, but had good quality. And I wanted to link the anterior to the posterior cuff, the superior capsular reconstruction story, but at the level of the lateral rotator interval, the cable side. So these are incorporating all the biomechanical features that we like and the biological features that we want. And so I reflected the pectoralis medial, major tendon medially. You can see that, did the shoulder replacement, put in, it happens to be another synthetic ligament to reconstruct superior and middle glenohumeral ligaments. And then the question was, well, what do I now do with the pec major transfer? It's no point putting it back where it came from because that's biomechanically insufficient. So what I did was to put in an Artelon patch shaped like the cable. You can see the parachute sutures coming down through the supraspinatus, actually quite a way back through the supraspinatus, and the strip cut to replicate the lesser tuberosity. Then that strip was taken up underneath the supraspinatus on your far left to integrate underneath the supraspinatus at the central region of that tendon. So that's my beginning of the cable reconstruction, or lateral superior capsular reconstruction, you could call it that. Then, exactly as Ron has pointed out before, there was a way of pulling that down across the lesser tuberosity to tension it without distorting the mesh to make it start to become ridged, because it's elastic in three directions, in three dimensions. It was then sutured to the deep surface of the pec major. You see the green arrow there. And that's the beginning of reconstructing the anterior cuff close to the joint line. So this is a way of creating a new type of capsule where it might be more effective. And then, exactly again, as Ron has pointed out beautifully, a very deliberate suture technique, not just point welding, but continuous suturing onto the lesser tuberosity. And then we fold the pec major back over the top and effectively bring sutures out through the Artelon, through the pec major in 3 rows. The distal row on the greater tuberosity, the middle row on the lesser tuberosity, and the medial row where the capsule should be. So that's where we've got our laminated repair. And I don't think I can do that with anything that doesn't carry sutures like a fabric, like that does, that is thin and not woven in the same way as other synthetic materials are, that are more tubular in their structure. They are bulky and don't have the porosity. They have too much elasticity in one direction. And this I've found very reliable for pec major tendon transfers, but also pec major repairs, triceps aponeurosis repairs, and rotator cuff augmentation. And you can tubulate it to become coricoclavicular ligaments, and you can roll it up and it becomes an AC joint disc replacement. And you can use it as an augmentation for the distal triceps, so trapezius. So wherever there's an aponeurosis that is failing, or a structure that needs directional orientation for healing, I have found it very reliable. And then reoperating on it, you've got actually really good quality tissue to reoperate on. So this for me has become my go-to. And when it was taken off the market whilst the Americans were deciding what they wanted to do with it, I just didn't know what to do. So I had a lot of disorganized thinking. Now it's back on the market. I'm delighted. Thank you very much indeed.
Thank you both very much for 2 excellent and very interesting presentations. We're now going to take some questions. There are some questions that have come through online. So unless there's any questions from the audience, we'll go straight to the online questions. So the first one is Mr. Donhoff. It's, Mr. Donhoff, do you routinely use MRI scans to evaluate graft?
No, 2 reasons. One is it's never been my practice anyway, even after primary cuff repairs. But secondly, if you perform an MR scan on this, interestingly, when you use T1 or T2 weighted images, what you actually see in the early stages is more or less a void. You don't see the graft. It's kind of invisible, isn't it, on the scans? If you want to look at whether the repair is intact, an ultrasound is probably a better
thing to use, because at least you get the reflection from the material. But an MR is not as useful. It's as useful as it is in any other case to look for whether your repaired rotator cuff is intact and has integrity. But in terms of assessing incorporation of the Artelon or graft jacket or anything else, but particularly Artelon, it's not that useful. So if you want to look at whether your repair is intact or not, I would go for an ultrasound scan.
Yeah, no, I think I agree completely.
Thank you very much. And another question is, given that you're putting your graft on tendon, which is a relatively avascular structure, how can we as surgeons ensure that we maximize the potential for neovascularization?
Well, one of the reasons I do open rotator cuff repair is I can't do arthroscopic rotator cuff repair, but the other reason is that I can save the bursa. And many, many, many years ago, it was a privilege to hear a guy called Hans Uthoff from Ottawa talking at the American Shoulder and Elbow Society, and he was saying, why do you all chuck away the bursa? It's the only source of blood vessels in the shoulder in a rotator cuff tear. And there was a lot of umming and ahhing and chin wagging and that sort of thing, and they then ignored him. But it struck me as being quite a useful thing to remember. And what I do is I always save the bursa, I operate, do the cuff repair, and then I use a bursal flap in the very big cuff repairs and try and bring bursa over this. So in terms of bringing vascular tissue to the piece, bursa is quite a good thing. And then I've mentioned I use biceps in the big tears because even a shaggy biceps has got some blood flow through it. And then of course, the cellular, the things that cause the angiogenesis is the cortex. So you do decortication and so on and so forth. No, so I use bursa.
Interesting. Ron, do you do the same thing?
Yeah, pretty much the same. I remember reading, I think that was published in the JBJS as well, wasn't it? A little bit later on. And it's surprising because it seems so obvious. This is a great source of vascular supply to the cuff. So with an open repair, you always lay it back on and incorporate it into your repair. You do the same thing here with an open repair. Interesting, obviously, that's not something you can do arthroscopically because you're spending half your time actually removing all that tissue. So you wonder whether the arthroscopic techniques, whether what you're gaining on one hand, you're losing on the other.
Although the results of primary arthroscopic and open rotator cuff repair are very similar, aren't they?
Yeah.
Well, Lou Brigiani's group in New York published, I think, last year, a comparative arthroscopic versus 2 years ago. And yes, at 6 months they're the same. But 1 year, the failure rate of the arthroscopic was climbing and the opens weren't. And at 2 years, the failure to heal and the retears were higher in the arthroscopic group than the open group. Now that's just one study. And you just have to ask yourself, well, why would that be? Was it because they had more anchor points? Was it because they mobilized the tissues more readily? Was it because they actually got new vascularity through a bursa? We just don't really know. People didn't unpick that one. All they said was, don't chuck away open rotator cuff repair as an option.
Very interesting. Another question. Given the fact that we're in a girthed world, getting it right first time, should we be using Artelon routinely for massive rotator cuff repairs?
Certainly, it's not been my practice. As I said in my talk, my practice would be to perform clinical radiological evaluation. Some patients you can predictably say this is a very large cuff tear in an elderly patient with tissue that on an MR is clearly delaminated. So those I would go straight to an augmentation graft. Some patients you will find that whilst technically you can repair them arthroscopically, practically, as Simon said, you're getting a few points of fixation in what now is maybe not delaminated, but poor quality tissue. So again, in that group, I would go back and do a second stage open repair on those with a graft. But I think other than those patients that you can predictably say will fail, that first group I've talked about, I wouldn't use it as a routine, but perhaps we haven't got the luxury of being able to bring people back to operations anymore.
Okay. Another question. How long does Artelon remain in the body?
I think Ron alluded to that, and perhaps I did too. 5 years. That photomicrograph is at 5 years, and it's still there, but degrading. And so this is the lovely thing. It has a profile that matches what's needed by your healing tissue. And we know that healing tissue goes on remodeling over 18 months. So you want something that is helpful in that. And so that's why I think that this material and things like it, if there are things like it, assists that healing process and supports it right through to the natural history of healing completion. Whereas all the allografts disappear at 6 months. And they're either disappeared, denatured, or completely causing infections, things like that, which is not very desirable.
And I think that's one of the other things those histological slides showed, that despite it being there for a very long period of time, you're not getting big giant cell foreign body reactions.
Yeah.
You're not getting all the undesirable elements of foreign material being present for a long time. So it is genuinely incorporating and then resorbing, but over a long time scale, which allows support and the ability to rehabilitate over an extended period of time.
Thank you very much. A lot of the questions that are coming in have actually already been answered in your talks, but I would like to ask, given the variability of outcomes after rotator cuff surgery and dependent on the quality of the tendon and the rehabilitation and these sorts of things, how confident are you that any augment does what we want to do?
From a clinical perspective, very confident.
I think so, yeah.
I think I started using it in patients who'd already failed. So these were people who were already in that bad subgroup. They were patients who'd had a apparently successful repair, which had then failed 9, 12 months later. And that I would re-repair them, and they failed again 6 months later. And it's that law of diminishing returns. Then suddenly Artelon came along, started doing that as by this stage, a third procedure. Suddenly we have patients who went from pseudo-paralysis to normal function after a standard period of rehab.
I think you mentioned GIRFT, and we could have a very philosophical discussion about that as a concept, but it goes back beyond the surgical procedures, and it goes back to diagnosis and which patients do you select for such augmentation. And that's where ultrasound is so handy, because if you know clinically you've got a tear, and that's not the difficult bit. What you want to try and predict is what's going to happen to the boundaries of that tear, front and back. Is it going to become an anterior pillar tear with instability, which is quite quick? Or is it going to be a posterior tear, which loses power, but could be compensated for over a longer period of time? And so the ultrasound gives you a clue. Is that tendon laminating and degenerating? And which side of the tear is it? Now, that means to me that if you've got a field change in the tendon that's witnessed by the ultrasound changes, that's the augmentation tendon. That's the tendon that should have augmentation. Whereas as a very discrete tear, the boundaries of which are very competent, and they don't look tendinopathic on ultrasound when you shift the arm around, then that tear doesn't necessarily need an augment, but that's likely to heal primarily. So I think it's possible to use good imaging and the clinical tests to decide which patient would be selected for augmentation upfront now. That's the GIRFT bit for me. The surgery is just technical, but its selection is the critical thing. And MRIs don't tell you that. Ultrasound does, really.
And would there be a role for anything like needle arthroscopy to aid you to kind of, rather than scoping them primarily with kind of arthroscopic and open procedure is not a good idea, but needle arthroscopy possibly?
if you want to confirm your diagnosis of is there a tear or not, needle arthroscopy may be useful, but it doesn't tell you about the intrinsic quality of the tendon that easily. I mean, if you see something that's shiny and tapered and inelastic and it's got a little wave on the edge of it, you know it's been there for donkey's years and isn't going anywhere. But you know that anyway from the history. So no, I'd like to be better at ultrasound with much more powerful dual absorption ultrasonography, so you could actually say something about the tissue quality and then say, right, if I don't repair your tendon in this year, it's going to do that.
Well, that's it for the online questions that we've got. Any questions from the audience?
Yes, I'm Chairman. We do a lot of knee work, and I just wonder whether there is application of this tendon graft in situations where you've got an area of defect, say perhaps in the body, such as tendon insertion of the patella, for instance. Does it have the tensile strength and the integrity to do with a repair of that nature, for instance?
Well, from a scientific point of view, I don't know, but we do know that the tensile strength far exceeds that of the tensile strength of both the normal rotator cuff and biological grafts used for any other form of tendon repair. So I would suggest yes. Interestingly, I've actually used it once in a patient who is steroid using bodybuilder who came in during one of my trauma takes, who had bilateral quadriceps ruptures, and I augmented both of those with Artelon years and years ago, and it incorporated in exactly the same way that you would expect. But probably with him, it was more a case of giving him that initial primary fix, which then allowed mobilization, so it didn't all become a complete adherent mass of tissue which wouldn't allow him to mobilize.
Yes, I agree. I think in that aponeurotic type of fixation, using something like Artelon as a sort of laminar, but also fixed at points through that, and that's where its suture retention strength is so useful, that you can then move the knee after that gently. So I would imagine it would be very useful.
I mean, traditionally, I don't take it as you can read through the tower and read it up.
Yeah.
So if it avoids doing that, then I think it's really good.
Yeah. I would agree. I think and the patches that are available are perfect for just that thing. It's just long enough for a patella tendon.
Interesting to know from the lavender team whether it's been widely used in Berlin. Yeah, lavender saying it's being used in the knee. Any other questions from the audience? Okay, so I mean, I just like to thank Ron and Simon for a really interesting debate and two fantastic presentations. I don't know if Fiona wants to say a final word before we finish.
Just to reiterate what Will said, and the presentations were both, excuse me, very, very interesting and insightful. I must admit, I do feel hungry for some sort of pasta dish for my dinner now, after Simon's analogy. But also, thank you very much to everybody for joining us as well.
Thank you very much.